in all. A warm welcome to this symposium session on mental health, entitled No Health Without Mental Health, the Southeast Asian Response. Coincidentally, today also marks the first World Bank event on making mental health a global priority. This overlapping event is also the reason that Dr. Tina van Bolter cannot be here, because she is actually has to be part of the Economic Forum on Global Agenda. You come in, please. At the World Bank and various other locations today. So that is her apology for not being able to be here. She is part of this much larger project, of which there is a web link there if you're interested. Today's Joint Bank WHO-WEF events since I started too early. Today's joint World Bank WHO-WEF events indicate and acknowledge that good mental health is absolutely crucial to our overall health and well-being and vital to a well-functioning society. Yet, all too often, mental health is seen as a taboo topic on one hand, and one thinks here about the persistent stigma around mental health. My own research has to do with aging in Indonesia, and as you will appreciate, older people are the ones who get marginalized because their capacities, even if they're very good, are somewhat less, and it becomes a progressive feature, which is a very important aspect of why dealing with the aging is difficult. We all too often see mental health as a taboo, or dealing with it as a luxury, especially when many people have to pay out-of-pocket healthcare costs. Unfortunately, mental health is one of the leading causes of disability worldwide. And if we were to give a ballpark figure for this country, estimates are that 1 in 5 people over the age of 80 suffer some form of mental disability. So I mean, we're talking about potentially, very large numbers of people as the populations gradually age. Well, please feel free to use the front row. There's nothing forbidding that.
Okay.
Now, in fact, we have, team has put together a very nicely balanced program for us. We have a speaker from Singapore, which obviously, you all know, is a high-income country from a Southeast Asian perspective, Malaysia, an upper-middle-income country in that context, and Indonesia, relatively lower in that context. Our first speaker will be Sabrina Anjara, who is a PhD candidate in public health at Cambridge. And she will introduce Indonesia's human rights challenges in mental health, the new mental health law of 2014, which I'm actually rather interested to hear about because I don't know the details myself, and 2 service delivery frameworks in her paper, Indonesia, State of Mind. So can I hand over to you?
So it seems that I will be stuck here because there is no clicker, and I'll have to press this manually. Thank you very much once again, Philip. Distinguished colleagues. Ladies, namely, and the 3 gentlemen. My name is Sabrina Anjara. I'm a psychologist by training and by profession prior to starting my PhD in public health. This year, I'm also a visiting fellow at Fakultas Psikologi, Universitas Gadjah Mada, that's in Jogja. Let me acknowledge my funders and my research partners. I'm going to ask everybody, what is health? So perhaps members of the audience can contribute to this. What is health? What do you think is health?
Sorry, what is health?
Health, yes.
Sense of well-being.
Sense of well-being,
Absence of sickness?
absence of sickness.
Absence of disease?
Very good. I know that you have someone with a background in English literature as well, so any other dimensions? We'll get back to that later. I'm sorry.
Security, certainty of cure?
Certainty of cure. Yeah. So also related to illness, disease. Today I'm going to talk about mental health as the Cinderella of healthcare. I'm going to talk about human rights violations towards people with psychosocial disabilities in Indonesia. I'm going to talk about the challenging geography of Indonesia and how the health system responds to it. I'm going to talk about the 2014 mental health law and its principles, my research also specifically, and its potential impact. So earlier, we visited the question, what is health? And being in Oxford, I thought it would be appropriate to look at the Oxford Dictionary. And the Oxford Dictionary defines health as the state of being free from illness and injury. However, the World Health Organization has a deeper dimension to what is health. And health is defined by the WHO as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The WHO defines mental health, on the other hand, as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution. We heard earlier about older members of the society who might be marginalized, especially in the Asian community. Sometimes we might say they're past their use-by date. So they're put on the shelf, they're no longer active members of the society, but of course they're a wealth of wisdom that they can contribute. Mental health disorders unfortunately reduce life expectancy by 8 to 17 years on average. I would dare to say that psychosocial disability are considered killer diseases. About 800,000 suicides annually are almost entirely attributed to mental disorders, and it is also indirectly contributing to 8 million deaths annually. That's about 14% of death. Studies have shown that on average, 15% of the population experience some form of mental disorders at some point in their lives. Philip's figure earlier was 20% for this country. Mental disorders also account for 28.5 years lost to disability and 10.4% of disability-adjusted life. In Indonesia, the figures are rather optimistic. I'm not sure if this has something to do with the way the data was gathered. In Indonesia, the prevalence of mental illness is only 6%. But 6% of our large population means that 15 million people experience some sort of psychosocial disability. Moving on to human rights abuses. Many of you would have come across the sudden spike of media attention around 20th to 22nd of March on abuses towards people with psychosocial disabilities in Indonesia. It was published by the Human Rights Watch, and very soon after, or together with the publication of the report, a host of other media articles were published worldwide on this issue. In fact, there's also an academic documentary on mental health, and also the human rights violations towards people with mental health are breaking chains. And the practice of pasung, that's the chaining of people with mental illness in Indonesia, has been well documented before the Human Rights Watch article. Pasung is the traditional practice of placing people with severe psychiatric disturbance in wooden shackles, in cages, in chains, sometimes chained to a tree, sometimes without shelter. And most of the time, this is done by family members who have no ill intention towards the person who's not well. It is traditionally thought as a way to keep people safe, to keep our family members safe from getting lost, from harming other people, from harming themselves. It is also relatively widespread in Indonesia. Violations towards the mentally ill, including removal of freedom and denial of healthcare and social services, is common especially in low and middle income countries. Arthur Kleinman, an anthropologist from Harvard University, calls this a failure of humanity. At the moment, the government of Indonesia estimates that 57 people have been or are currently in pasung. Most recent figures from the Human Rights Watch estimate that currently 18,000 people are in pasung. What could be the cause of this? Treatment gap is defined as the amount of people with psychosocial disability who are not in treatment or are on inadequate treatment, expressed as a percentage of the total. This is caused by a general lack of public awareness on the biopsychosocial causes of mental disorders, resulting in stigma towards mental illness. My colleague Lionel worked on stigma towards mental illness in Malaysia previously. You can ask her more about it later. People with mental illness may be considered demon-possessed, sinful, cursed. They are labeled crazy, and their families shamed. This leads to low demand for mental health services. As demands are low, few medical graduates are interested in the psychiatric profession. Traditionally, psychiatrists in Indonesia provide public mental health education. And unfortunately, this cycle contributes to a very large treatment gap. I'll talk about the geography of health next. As many people in this room, I think most of the people in this room are Indonesians, my next audience participation question is kind of useless. But I'll try anyway. For the non-Indonesians in the room, out of the 5 big islands in Indonesia, which one is the one with 65% of the population?
Sorry, can you repeat the question?
So Indonesia has many, many islands.
Yeah.
But out of the 5 biggest islands, which one is the one that's home to 65% of the Indonesian population?
Non-Indonesianists should answer.
Yes. I'm the neighbor. I will attempt.
You know, I've worked in Indonesia for the last 30 years, so I'm not qualified.
Sumatra,
Me.
Papua, Sumatra.
Sumatra is big, Papua is bigger.
But yeah, it depends on Papua. Is
Yes,
quite like
yes.
scarce as well, right? I think the dense one is either Java or Sumatra.
Java.
Java.
Java is the answer. Java is the smallest of the 5 biggest islands, but it's also home of 65% of Indonesians.
Really?
So Indonesia is geographically challenging for governance, development, and health systems. It is ethnically diverse, although the majority of people are Muslims. The World Bank classifies Indonesia as a lower middle income country. Health expenditure is around 3% of government budget, while mental health spending is about 1% of that health budget. Which is why I call mental health as the Cinderella of healthcare, because if you look at it, mental health issues are responsible for 28.5% of years lost to disability, but our government only allocates 1% of its health budget to its mental health. Health infrastructures in the country does not adequately meet the needs of the people, especially when 65% of the people are concentrated in Java, which also means that 65% of doctors in Indonesia are practicing in Java. Probably interesting, probably not interesting to you. The figures that are shown earlier are even more shocking for mental health care. In early 2015, and this is the latest government data on psychiatrists, Indonesia is served by 773 registered psychiatrists, and we have 250 million people. The UK in comparison has 8,700 psychiatrists for about 86 million people. So it is not a surprise, perhaps, for many of you that treatment gap is very high. And treatment gap in Indonesia, according to government research, is more than 90%, which means only 1 of 10 people who need mental health care is actually receiving care. The colonial government, back in the late 1800s, recognized that the enormous size of the country, which spans the distance between London to Tehran, makes it impossible to build and manage enough accessible hospitals. This is because the population density in many rural areas in Indonesia means that running a hospital there is not economically viable. The result is a focus on community-based care. In the years following independence, the Indonesian government also focused on building a network of primary care centers in the country. At the moment, Indonesia has close to 10,000 community health centers, also known as puskesmas. 63% of them are outside Java, and it might surprise you that a third of them provide inpatient overnight facilities. The UN Secretary General Ban Ki-moon, in his speech on the World Mental Health Day in 2009, said that providing effective mental health services in primary care setting would help to reduce the stigma associated with mental disorders and could prevent unnecessary hospitalization and human rights violations of people with mental health problems. Such strategy would make good economic sense. It is also a pro-poor strategy. And may I elaborate further? It is a pro-poor strategy because latest research show that being poor means you're more likely to develop mental disorders. And I think based on my work experience in Singapore, the government of Singapore is also focusing on lower income families because this is highly associated with the prevalence of mental disorders. Let me move on to mental health legislations. Mental health legislations to date. Indonesia has gone through a number of versions of health legislations. The first mental health law was decreed by President Suharto in 1966, very shortly after he gained power of the country. Considering it was a period of political turmoil, efforts for ground-level implementation were very limited. Indonesia then became the model within ASEAN for mental health. A lot of ASEAN countries look to Indonesia that has received the support of UC San Diego to develop its mental health system. Unfortunately, in 1992, the General Health Law superseded the 1966 Mental Health Law, which was also accompanied by the reorganization of the Ministry of Health. The Directorate of Mental Health, that used to be a standalone directorate in 1966 all the way to 1992, was then subsumed under General Health. This also means that the budgets are lower. This also means that a working project has to fight or compete with other projects such as infectious diseases. In 2009, there was a revision to the General Health Law. And fortunately, this time around, after learning from the tsunami in Aceh, there are provisions for mental health care in the revisions. However, it only talks about provincial governments being responsible for providing mental health care without detailing how it's going to be done. In July 2014, the Indonesian parliament approved a new mental health law. This is a year after India's mental health bill and 2 years after China's mental health law. The 2014 mental health law is based on the following principles: justice, humanity, beneficial impact, transparency, accountability, comprehensiveness, protection, and non-discrimination. It might surprise you that there are specific clauses for transparency and accountability embedded in Indonesian law. Sorry. I see some smiles in the room. It is uncommon, I guess, to have accountability and transparency written in the law. In any case, the approach is very modern and international, although there are still loopholes with regards to the participation of people with psychosocial disabilities in making a decision on their own treatment and in other citizenship activities like voting. There is a focus also on integrated, comprehensive, and sustainable service provision with a life course approach, as well as a focus on the accessibility and quality of care. The law, the new one, was rather evidence-informed. I will not say that it is evidence-based yet, and arranged according to a public health model of health promotion, prevention, intervention, and rehabilitation. I would say that this law, in comparison to other lower and middle income countries, is considered cutting edge, at the forefront of science, and very modern. Let me direct your attention to my research project. So earlier we talked about the cycle which perpetuates a large treatment gap. There are various ways to reduce treatment gap. Stigma intervention, for example, increasing qualified manpower, of course, but there are also short-term strategies that we can consider. The government in 2010 implemented a new program called the Bebas Pasung program, that's the Free from Pasung program, which outlaws the practice of shackling people with psychosocial disabilities. The program was supposed to end in 2014 and result in 0 Indonesian being chained. Unfortunately, recent changes to access to healthcare means that in order to access free healthcare, one must own a card which details your citizenship of the country, so something like a KTP, and also Kartu Indonesia Sehat before you can access free health services. Unfortunately, for someone who has been in shackle for 3 or 4 years, the person might not even have an identity card, and obviously not a Kartu Indonesia Sehat. In recognizing that there are these problems with the implementation, the Bebas Pasung program was extended to 2017. Another short-term strategy that we can do is to increase service capacity through task shifting or psychological services in primary care setting. So this is what my research is focusing on. Top right. This is the proposed care pathways. When we identify someone with psychosocial disabilities, the hope is that they would enter one of the almost 10,000 primary care centers in the country. They will be given treatment by either pairs of GPs and nurses who have been trained, or also psychologists who work at primary care centers. I'm looking at 2 frameworks. The first framework is the WHO mental health gap. May I ask the audience who's familiar with this program? Aside from my 2 colleagues who will be speaking later. Anyone? Yes? Yeah? What do you think of the program?
Well, it's very, it's a general frame which is self-evident, but then implementation is, of course, very, depends on so many different items that it doesn't mean much in a certain way because of this.
Thank you. So As you say, the WHO Mental Health Gap Action Program is a tool, some would say, or a curriculum, as others would say, developed by experts on mental health and global mental health, based on their various research works in many countries around the world, most of them low and middle income countries. And the curriculum aims at scaling up services for mental, neurological, and substance use disorders, specifically for low and middle income countries. It involves training pairs of GPs and nurses in primary care facilities to be able to detect mental illness, to be able to provide proper care, psychological assistance, and medication. It was translated by the Indonesian Ministry of Health last year in 2015, and training for that also began last year. And it is currently 9 p.m. in Jogja, so a few hours earlier we have just completed the training of 14 pairs of GPs and nurses from primary care centers in Jogja. The second framework is the clinical psychologist framework. This framework started in 2005. It's been going on for about 11 years. The District Health Authority of Sleman first contacted the Faculty of Psychology in Universitas Gadjah Mada to channel their Masters of Clinical Psychology graduates to primary care centers. They gained civil servant status. All of them work for the government. There are 43 of them currently in primary care centers in Kota Yogyakarta and also Sleman district, so only in 2 districts. In January 2017, it will be rolled out to a 3rd district. For many of us, it might seem impossible that we are placing one master's level clinical psychologist in every single primary care center. It doesn't even happen in the UK. You don't expect to go to a GP surgery or, well, for people who are still studying their college nurse practice, for example, and hope to also find a master's level clinical psychologist working there every day of the week. This is managed and supervised by the Center for Public Mental Health in Jogja, who manages the continuing professional development for these psychologists and also check on their patient records, and not just that, whether the diagnoses are done correctly, case conferences, case presentations, how do you manage difficult cases and things like that. So it's a comprehensive framework. It's been running for about 11 years, but unfortunately nobody has looked at it yet, until now, of course. So my research objective is to compare the WHO Mental Health Gap Framework with the Clinical Psychologist Framework in Jogja, to determine the clinical and cost effectiveness of both programs, and to propose one framework or even a combination of these frameworks to be replicated in other provinces in the country. Moving on to my support structure, I receive a lot of support for this project, ranging from the central government, provincial government, and also health authorities. As I found out, even this amount of support is at times not enough to move things, but that's for another conversation. So moving on to my research methodology, I've done my due diligence and I'm currently waiting for a second ethical clearance. Otherwise, we should be ready to go anytime. So this is what I plan to do throughout my PhD, and at the moment we are pending data collection. That's the 4th box from the left. The design of my research project is cluster randomized controlled trial. May I ask who is familiar with randomized controlled trials? Again, my 2 colleagues. Yeah? So that's great. So recently, global mental health as a field have moved towards cluster randomized control trial because we feel that a normal randomized control trial is not very ethical. Because a normal randomized control trial involves placing patients at random to a treatment group or a control group with no treatment. So fortunately, we have two frameworks to test, and one has been going on for 11 years. So we're treating that one as treatment as usual, and the other one as our experimental group. Cluster RCT is still supposed to remove bias because our clusters, or our puskesmas, are chosen at random. Each clinic will only provide one modality of treatment to minimize contamination effect. Each cluster, each puskesmas, each clinic has to recruit at least 15 participants for statistical power. Fortunately for me, all puskesmas in Yogyakarta province are ISO accredited. This means the flow of patients from the registration table to the time they exit and pay for the services are the same all over the province. This also makes the flow of patient recruitment easier and more organized. When patients come into a puskesmas in Yogya, patients pick up a queue number. When they pick up a queue number, they will be given a screening questionnaire. It is compulsory for all patients in primary care settings in Indonesia to be measured for their blood pressure. Even if they are at the puskesmas to see a dentist, the blood pressure would also be taken. So as they fill up the questionnaire, they wait for blood pressure measurement. The nurse who takes a blood pressure measurement will score the screening questionnaire. If patients are eligible to participate in the program, or in other words, if patients show signs of common mental disorders, they would be asked if they would like to participate in the project. Otherwise, they would be referred to the doctors or clinical psychologists in any case by the nurses. While they wait to see their doctors or clinical psychologists, they would also fill out 2 other questionnaires. And the clinician will then make a diagnosis and give them a treatment plan, after which they can go on with their normal complaints, and then they can proceed to pick up medication if needed and then pay. So I have a number of measures. These are my patient outcome measures. The screening questionnaire that all patients will get, all puskesmas patients will get, is the general health questionnaire. It's a simple 12-item questionnaire. And I also have other instruments on disability, quality of life, and also symptoms and severity. For cost effectiveness, I have these 2 measures: societal cost, as measured by the client service visit inventory, and also health services cost. Clinical data will be collected at baseline, 6-month and 12-month follow-up, and will be analyzed firstly on intention to treat basis and per protocol basis. Cost data will be collected at 6-month and 12-month follow-up. Cost utility analysis will be done primarily by looking at the dollar cost of improving quality of life. So this is reaching the end of my presentation, which is why I come up with this picture. So at the moment, I'm unfortunately underfunded for my research. I've only received about 40% of funding. That's from the University of Cambridge. I'm not eligible to most other funding in Indonesia because of the 40% of funding from the University of Cambridge. So I've requested assistance from LPDP, the Indonesian Education Endowment Fund, but because I have received some money for my research, I'm not eligible for additional funding from them. As such, I've embarked on a crowdfunding project to raise funds for this clinical trial, and I hope that you can spread the word. Who knows, maybe anyone from your network might be willing to support this project. potential impact of this project, the most immediate impact would be on individual patients and immediate family members. This will also positively influence their participation in society, socially and economically. For the country overall, the societal, legal, and economical cost of mental health issues should be reduced. How? The research findings will directly impact on ground-level service provision through introducing a screening mechanism which will continue beyond the end of the project. This research study will also provide empirical evidence of clinical and cost effectiveness. It would also help to formulate qualitatively implementation challenges on the ground. All this while we improve access to mental health treatment. May I take any questions?
I think what we'll do, for the moment there'll be questions about information. We'll take questions for all three speakers at the end. I will say to the other speakers, in fact, if we're not careful, we won't have any time for discussion. But please, go ahead.
So, I have a question about the outcomes. How long from the treatment are you going to measure the outcome? And whether, I'm not familiar with mental health as well, so how do you measure, like, this is significant differently than the regular program?
So of course, statistically, we have repeated measures tests. We will measure at baseline, 6 months and 12 months. So during that time, so basically every 6 months, patients will have to recall how many times they've attended sessions at the Puskesmas, how much medication have they been prescribed during that period, and also, of course, there will be clinical interviews and also self-reported measures on the outcomes. So patients will rate their own quality of life and their own disability relative to the 2 weeks prior to filling out the questionnaires. So we have both patient-reported and clinician-assessed.
And you think 12 months is enough for them to actually get the treated differently?
So 6 months and 12 months, of course, we cannot guarantee that there are marked improvements, but the data would be able to tell. So we are assessing, of course, for statistical significance.
Any other points of information? Please.
Thank you for the presentation. I don't have I'm a lawyer. I work for a human rights organization in Indonesia, so I know nothing about mental health. But it's interesting for me because, you know, like you say, there are so many human rights violations to these people. My question would be like, how are you gonna address the stigma? You know, like when you expect people to come to the service, you know that they face some barriers. You know, like even to go to the center,
Yes.
they need someone to walk with them. They need someone to, and the family also, the stigma against the family. How are you gonna deal with that?
So thank you very much for the question. That is a very, very practical question. Stigma in Indonesia is very strong if you take your family member to see a private psychiatrist or psychologist, because everybody can see that this person enters a psychiatric facility or enters the queue for seeing a psychiatrist at a hospital. But it is very different when patients go to a Puskesmas, because everybody goes to a Puskesmas. Pregnant mothers go to a Puskesmas. Little babies go to a Puskesmas. Nobody knows at the point where a patient sees the doctor what is the complaint about. It is only between the doctors and the nurses and the patients. So this will hopefully reduce the stigma.
I have a question, but I think I better ask it at the end.
Fine.
It's more radical.
Yeah, and at the moment we're just asking points of information. I have one little question, which is that you've dealt with, in a sense, common mental disorders.
Yes.
And what do you expect to be in your sample? What are the main mental illnesses that are likely to turn up this way?
Yeah.
And are there any that might not?
Yes. So research has shown that 20% of primary care patients have common mental disorders,
Mhm.
and that includes depression, anxiety, and perhaps first episode schizophrenia. So I don't expect that there's anything else.
So-
Okay.
And related, it can be identified just by filling up a form?
Yes.
Yeah.
Of course, it should be accompanied by a clinical interview, and which is why.
So you will post every clinical interviewee in each puskesmas?
The clinical interviewers
Yeah, sorry.
are
interviewers.
actually the doctors and nurses who have been trained in WHO mental health.
So you will train, you already
Yes.
given them training?
Yes. So in Jogja, for my study in particular, it just ended today.
Okay.
Anyway, thank you very much, Sabrina. And we'll have questions for all three of the speakers at the end. I have the pleasure of introducing Ainul Hanafia. I hope I didn't mangle that too badly.
That is on point.
Who is also a PhD candidate in public health at the University of Cambridge. We move now to Malaysia's mental health policies and their implementation. Thank you, Ainul.
Okay, I hope firstly that you guys can always see me. I'm kind of small. Yeah, that's always my problem. It's like I really have to like sort of like stand up, but then I kind of have to stand here because there's no clicker. But anyways, thank you, Philip. As you all have been introduced, my name is Ainul. I'm actually a third year PhD student, 3 out of 4 years. So I'm now at a very crucial point of data collection in Malaysia. So my presentation today will actually cover one small part of my study, and I'm pretty much just reporting it. And unfortunately, preliminary data are still in progress, and I can't actually share that just yet. So this is just the literature review part, and I have condensed it in a few slides rather, in this few minutes. But we hope to actually get it published as soon as possible. It's now in the works. So yes, the topic of my presentation is mental health in Malaysia. Are we on the right track? Okay, it's a bit. So before I begin to speak about the mental health system and the mental health in Malaysia, I think it's rather important for you to understand the demographics and the country profile of Malaysia, because just like I was listening to Sabrina, I was actually quite rather surprised to know that I don't actually know a lot about Indonesia, even though we're actually just neighbors. And I have to thank her for giving a good introduction of mental health, like globally and pretty much on Indonesia, which then does sort of apply to Malaysia, because at the end of the day, it's like culturally we are quite similar in Malaysia, except that we do have a bit more diversity in terms of our ethnicities, and that on its own is a very interesting factor, affecting mental health in Malaysia. So, Malaysia, unlike Indonesia, there's only 2 parts of Malaysia, highlighted in orange, and we have about 30 million of us, and this is as of 2013 statistics, and we have about 26% of Malaysians are under the age of 50, and we are quite a young country, because only 9% of the population is aged over 60. And the median age is 27 years old, so yeah, relatively a young country, and population living in urban areas is 73%. And do you want to take a guess where that 73% actually is?
Slow.
Well, which, and the left? Alright. Yes, thank God. There's only like 2 parts of us. Sorry. Yes, exactly. So 73% out of it is like densely populated in the West Malaysia, whereby East Malaysia is still rather an rural population and like rural areas. And as Philip had mentioned before, we are an upper middle income country, and well, we are considered as the Western Pacific under the WHO region. Okay, enough about Malaysia. Well, the country at least. So this is, for you to understand the mental health system, I believe it is important for you to first, for me to walk you through the provisions of services in Malaysia. So in Malaysia, public and private healthcare is relatively, private care especially is relatively accessible. For example, in the UK, the NHS is pretty much the life of the citizens. But in Malaysia, it's like people from like middle income economic background can pretty much access the private care. And although the public care has been designed and categorized in a very proper and detailed manner, the private hospitals still do get a lot of attention. And as you can see over here, we have public health and prevention, we have clinics, we have hospitals, we even have special institutions, of which psychiatry is one of them. So we still do have, unfortunately for me to report, that we still have about 4 psychiatric institutions, but these are meant for more like severe cases where the patients are deemed, untreatable, and therefore they are being restrained, refrained in the institution. But from what I understand, I don't think Malaysia's situation is as severe or as bad as Indonesia, because I have visited one of the institutions before, and yes, although they are refrained, but it's more of because they do get violent, and they are not refrained or restrained 24/7. So the doctors do try and encourage them to, sort of move around and move about. But the state of the patients over there is really quite sad, and some of them are not even pretty much, they're just out of touch with reality, really. So yes, and these are some of the other institutions that we have. And the interesting part is that we have Department of Orang Asli, which pretty much is an institution for indigenous people. So especially in the east of Malaysia, there are a huge number of ethnicities, by which even I don't actually know much about them, but they are considered the indigenous people of our country, and therefore more in Sabah and Sarawak, the east of Malaysia, they do have indigenous hospitals, which I have not been able to access myself. And under the Ministry of Home Affairs, we have Drug Rehab Center. So although this falls under the mental health system, it does have its own special forces or authority that overlooks it. So it does not necessarily just fall under the Ministry of Health. It's more of like a collaborative work between the Ministry of Home Affairs and Ministry of Health to address on the drug rehab centers. And the Ministry of Education, under them, we do have university and medical schools and university hospitals. I do believe, like, similar to the university that Sabrina is attached to, it's of a similar nature. Whereas under the private care, it's rather simple. We have hospitals, clinics, which is equivalent to the GPs here. And then we have the estate and mines hospitals, because well, mines not too much anymore, but we still do have quite a number of plantations around Malaysia, especially palm oil. So I have personally worked with a big conglomerate of palm oil, and I have visited, and companies like my ex-company, they do spend a lot of money, to invest on the healthcare and education of their their employees, especially those in the plantations, because they are quite, isolated from the towns, and sometimes just for them to go to the town, it takes them like 2-3 hours, by road. So therefore, companies do tend to have specialized clinics there to provide them the care that they require. And also clinics in factories and industrial areas is quite a common practice in Malaysia to have those. And we also have private traditional medicine, and I think like it's an uprising sort of like market nowadays, especially in Asia, to have what we call the TMC. And of course we also have private dental practitioners, pharmacies and such. I think that's quite common as well. So what's interesting is that for the private care, it's mostly curative and diagnostic health services, and it's largely in urban areas, therefore West Malaysia. And from my study, I have been able to identify that in East Malaysia, the less urban part of Malaysia, the citizens over there, the population over there still do rely heavily on government care, really public care, and private care is not as popular as for the citizens in West Malaysia. So even though we're one country, but because of the sea that we're being separated by, it's interesting how even the health system is affected by that. And most of the private care are insurance or out-of-pocket, and like as I've mentioned before, it's mostly accessed by middle to high-income consumers. And currently, the market share for private care for hospital admissions, the 18%, so 82% still tend to get themselves admitted to public care, simply because it is quite expensive to be admitted in a private facility. Whereas for outpatients, like for example GPs or any of those like dental, pharmacy, it is very, very common. In fact, 63% of the market share is in the private care. So, for medical conditions that are not very severe, we tend to access the private care, and by we, even myself. So, as I've mentioned before, this is just a quick sort of like snapshot of how the financing works. So under the government, they have their own budget, and then once you work as an employee, you get 30% of the employee provident fund, which is essentially your pension, and 30% of the pension can be withdrawn for health purposes. And we also have the social security fund that is contributed by the employee, and usually the employees tend to contribute a lot more. So all of these can be utilized for your medical care, whether it's public or private. So it's not just sort of like limited to public care. And of course, as mentioned, we have the private insurance premiums, and private companies tend to include that in their benefits package. So that's why I believe that for us to access private care, it's quite sort of automatic, like by default, we will just straight away think private care first, and then if it's severe enough, and then we will then move to public care. And of course, out-of-pocket payment. So mental health care, I would like to now then introduce you a bit to our system. Okay, so pre-1987, the model was institutional. As mentioned, the 4 hospitals, which is located on the north and south side of West Malaysia, and then 2 in East Malaysia in each of the states. So in East Malaysia, there's only 2 states, Sabah and Sarawak, and they each have their own institutions. So pre-1987, that was how psychiatric care or mental health care was administered. And it was mainly medically oriented, and the target population is mentally ill, and it's custodial of nature, curative, lifelong. It's pretty much what you would expect, you know, a psychiatric institution would be, and so that is pre-1997. Post-1997, I will walk you through why I'm using pre-1997, post-1997. So the government have actually decided after an uproar of, you know, people being mistreated just like Indonesia. So we went through a bit of an uproar as well, but it's just that we were not as publicized in the newspaper, because at that point it was 1987, so we are spared of social media, so thank God. But even then, the pressure was enough to push the government to form a community mental health program, and therefore the system was then reorganized to be deinstitutionalized and community-based, and it focuses on mainly psychosocial treatments. Although the target population is still mentally ill, but the focus is to normalize the mental health conditions, rather than it being treated like it's a disease, you are a problem, and therefore we will, you know, put you away. So the approach is to try and make mental health conditions into, you know, just another medical condition that you should not be afraid of. And the practices include social environment, and developing living and coping skills, and making it a more community-based services closer to home. And then the government also focused into integrated and decentralization, meaning at that point, even though it was deinstitutionalized, the focus was still mainly in hospitals. So psychiatric wards was still the main component, but then you know, the integration that I am referring to right here is to make it more of a public health approach, therefore primary care settings. So in Malaysia we have you know, health centers like Sabrina's Puskesmas. That one. I'm sorry. So it's like the equivalent to that in Malaysia are health centers and health clinics, which is mainly you know, in communities, and that is trying to integrate the mental health care into our primary care settings, and this was targeted towards wellness concept and for healthy people and people at risk. So it's a more sort of like integrative manner. It's not just targeting people who is already ill, but also people who's healthy. That means you know, promoting of mental health, and you know, should there be people at risk, you know, prevention and early detection are amongst the focus of the integrated and decentralization approach. Okay, and as I've mentioned, post-1997, community mental health program was introduced. And the Ministry of Health at the point defined mental health, you know, to Malaysia. What mental health means is the capacity of the individual, the group, and environment to interact with one another to promote subjective well-being and optimal functioning, and the use of cognitive, affective, and relational abilities towards the achievement of individual and collective goals consistent with justice. So as you can see right here, Malaysia, even the definition of mental health is very much focused towards collective society. As you can see, interact with one another to promote subjective well-being and goals consistent with justice. And justice here means not just yourself, but also your family, your bigger society, your employer, and we. Yeah, and this actually reflects, as I've mentioned, Malaysia is a country of multicultures, and this reflects the multicultural underpinnings, and the societal emphasis is placed on caring and giving, and providing trust and support. And a good outcome, one of the best outcomes from the Community Mental Health Program 1997 is the National Mental Health Policy. So prior to that, we did not have any policies, although we did have laws, but it was laws from 1920s, and we had one law specifically for West Malaysia, and we had two laws specifically for Sabah and Sarawak. So Sabah had one and Sarawak had one. I am still trying to understand, and which I have not been able to access the information as to why was there such laws, being differentiated in those states and West Malaysia. But the nature of Malaysia has always been like that, which is not necessarily the best. But then I do believe it is really because we take into account the cultural differences, even between West and East Malaysia. So the National Mental Health Policy, they had three goals, which is to provide the basis in developing strategies and direction for planning and implementation, and then to improve the overall mental health services for population at risk, and to improve the existing psychiatric services. These are pretty much, very generic and goals that I do believe like every country would have. And the second best thing that came out of the 1997 Community Mental Health Program is one single law that applies to both West and East Malaysia. That is the Mental Health Act 2001. So it was, in works since 1997, and the bill was passed in 2001, and this is what we are currently abided to. So, as I have walked you through a bit of the background of mental health in Malaysia, I bet you now the current question is, so what is the state of mental health in Malaysia? And as my colleague has enlightened you of Indonesia, I would now take the pleasure to walk you through the Malaysian one. Okay, so this is the data from a global study that was conducted in 2010 and was published in 2013. And globally, for a global study, this is the most recent data that we have. And as you can see over here, at number 3, number 3, yeah. Major depressive disorder is the top, in the top 25 causes of disability-adjusted life years. Just for me to quickly give you, in case you're not very much aware of what dailies mean, it's disability adjusted life years, which takes into account the years lost to disabilities and the life lost to disabilities. So dailies is a component of both. But then we also have specifically just on the years lost to disabilities and years lost, well, life lost to, years lost to the life lost. Oh, that's a mouthful. But yeah, so, mental health condition is not only at number 3, but also as you can see there in number 10, anxiety disorders. And this is taking into account of a 50% increase. And although HIV/AIDS is the highest percentage change over there, but right now major depressive disorder is in the top 3. And this is the chart for the years of life lost due to disabilities, the YLDs, by cause and age in 2010. And as you can see over here, I mean, sorry, the color is not like very obvious here, but this is actually light green. And the first thing you can see, and what should grab your attention, is that there's a huge sort of like charts, and it's just very prominent, and that is actually mental and behavioral disorders. And that accounts to major depressive and anxiety disorders alone contributes to 1 million years lost to disabilities. So for a 29 million population country, 1 million is still a big number, and this is there's still debate as to whether the 1 million is even accurate due to some factors that I will discuss with you in a short while. So that was in 2010. However, there is a more recent statistics of the dailies, YLs and YLDs for Malaysia. That is in 2012. And once again, neuropsychiatric conditions. It's no surprise because even in 2010, there's already been a huge rise of it, and attention was towards mental and behavioral disorders, and therefore for us to see neuropsychiatric conditions second leading dailies, cause of dailies, it is no surprise really. So as you can see over here, the longer bit of the chart is the years of healthy life lost due to disabilities. And as I said, 1 million is the current number, the present number as of 2013. But whether it's really accurate, that's for us to see. So, mental illness is the number 1 cause of years lived with disability in Malaysia. So you would think that people would be more empathetic, more aware, or just generally, gives a lot more attention to it. Unfortunately, studies have shown that there's a general negative attitude towards people with mental illness, and quality of life of people with mental illness is negatively affected. And mental illness has an adverse impact on social relationships, financial independence, and employment opportunities. And speaking from someone who's been doing interviews, so like for my study, I do interviews with the mental health stakeholders, comprising of the policymakers, the mental health professionals, the service users, NGOs, and the informal carers, caregivers. And based on what I have, the data I have gathered so far, these are all still true as of 2016. And mental health leads to a risk in decreased help seeking, care and support, and functioning within society. And as my colleague has mentioned, stigma. Stigma is the huge sort of like obstacle in mental health, which you can ask about later, because I have worked on stigma, but it's not for me to speak right now. And yes, as I have mentioned, although the statistics are rather alarming, 1 million years of life lost to disability as of 2016, but there are still, questions around the numbers because it may be underrepresented due to it being limited to hospital records. So as I mentioned, the system now is decentralized. So not a lot of the records will be held by the hospitals themselves because the health centers would hold a lot of the information as well. But for whatever reason that I still, we're still quite puzzled about, only hospital records are being taken into account for such a global study. And stigma may have prevented patients from seeking treatment. And again, private healthcare records are not included, which is quite an alarming, matter because if mental health is something, that is being seen as an outpatient service, that's 63% of the population accessing the care. However, they are not being taken into account in this. So 1 million could actually be 5 million for all we know. So bringing to the question as to whether Malaysia is on the right track, because we have the community mental health program that is still ongoing. Ever since 1997, there are a lot of initiatives supporting the mental health policy, a lot of action plans that have been, designed to support the goals, the 3 goals that I have mentioned. However, that is why my PhDs come about. I was very intrigued to understand, although the mental health policy was there, the plans, the action plans, the initiatives, and any sort of strategies that supports the mental health policy was not easily accessible. And therefore, I had to do a bit of a narrative review on, what is the development, the mental health policy development like in Malaysia, because literally the information wasn't there. You had to do a lot of work, you had to do investigative work for you to then find out, and that is why it brought me to this. So it was systematically searched using very specific terms, and it was searched in PubMed, PsycInfo, Scopus, Google Scholar, and even the social science network database. So these are all academic database, and I'm quite sure a lot of you may be aware of it. And it focuses on national development of mental health service in Malaysia, including policies, because I wanted to see, yes, you have this huge, community mental health program, and you have, done deinstitutionalization, you have these initiatives that is very much obvious and tangible, but how about the more finer things, like your action plans? What are the things that you are doing to make sure the implementation is happening? And from the thousands of papers that I had to go through, and I could not do a systematic review like what a lot of academic students would do, because these were not randomized, controlled trials. It wasn't just possible for me to quantify it. Therefore, I had to take a narrative literature review, because it allows me to look at it from a more qualitative aspect. And it was then the information that I looked in the papers were then identified according to themes. So 6 papers.
I know. We're in danger of not having any discussion.
Okay.
Porsche still has to talk.
Yeah,
so
I'm
wide up soon.
Yeah. Okay, sure. That's all right. So 6 papers were fit into my very sort of rigorous focus, which is on the national development. And the findings is that, okay, the strengths from what I've seen from the papers is that all the papers did agree that institutionalization of mental illness were criticized, and the negative impact of the restraint model acknowledged, and community-based service was viewed as an imperative model of care. And all the papers did mention about Mental Health Act, the integration into primary care settings, and psychosocial training, even prevention and promotion of mental health. However, the limitations of what I found are these. There are a lot of discrepancies of reported initiatives. So one paper may have mentioned extra than the other paper. So if this is a development and it's been done at the government level, should it not be a rather similar approach that should be reported? But that was not what I found. And it was lacking structured strategies or action plan and detailed policy guidelines. And all the papers mentioned that severe shortage of mental health personnel attributed to the inadequacy for better care. And unfortunately, systematic studies and research monitoring and evaluating the outcomes were not available. Even though this was implemented in 1997, up until 2015, there were none of those. And the literature on policy development was too few, because all I found was 6 out of the thousands, and only 6, met my criteria. And that is just quite a scarce number. So to conclude, are we on the right track? Yes, but more needs to be done. And evidently, the numbers of people being disabled by mental health conditions are increasing. Studies, especially in monitoring and evaluating the quality of care, are still scarce. And that is why I'm currently doing my PhD, which you can ask me about probably later. And that is all. Thank you.
Thank you very much, I know. Are there any questions? Yes, sorry. Are there any questions of points of fact? That it was very clear. Porsche, you're on.
Yes,
Our
okay,
next
I'm coming.
speaker is Porsche. We have, if you like, a kind of shift of gears at this point, not merely that we're moving to a third country, but a rather different perspective, because Porsche is the director of a mental health NGO called Silver Ribbons in Singapore, and therefore I think we will have a different perspective on these issues.
Thank you. Thank you, Dada.
I'll do a fast one. Good afternoon, everybody. How are you today? You're talking about mental health, right? Yeah. So my presentation won't be research-based. Not too many of the figures. We can talk days and nights about mental health. But the thing is, we can go on talking about the extent of stigma. But what are we doing to fight stigma? What are we doing to encourage early treatment? So this is something we would like to share. Can I have a show of hands? How many of you are presently involved in a mental health project, or from either a psychologist or a researcher on mental health? How many of you? Sorry? How many are involved in a mental health project or in mental health areas except these two? Soon. Okay, good. Interesting. So, yeah, thank you. We talk about dementia. So, can I have a show of hands? How many of you will seek help immediately if you have a mental health issue?
Yes. What will we do? How many?
What will you? How many of you will come forward to seek for treatment if you realize that you might be having, a mental disorder? How many of you will come forward?
Sometimes I don't even
Yeah.
know that I'm
Yeah.
having
Yeah, good. So the thing is, delayed treatment could be, one of the reasons for delayed treatment could be lack of knowledge. They are not aware, lack of insight. In addition to maybe extent of stigma in that particular country. But we're going to talk about this, okay? Advocacy is a very strong word for Singapore. I've been told by the government, Portia, can you avoid using the word advocacy? Yeah. So I can do it freely in UK. Thank you. Yeah. So that is briefly about Singapore. So I'm not sure how many of you have traveled to Singapore or visited Singapore. Of course, we have somebody from Singapore as well. So the thing is, Singapore is a very small country. I'm not going to challenge you like both of them. Which part of Singapore? Which part of Singapore has the most
Where is
population Singapore. Singapore is so tiny. Singapore is so tiny. Look at that. 718.3 kilometers. So we have a very small population, 5.54 million of people. So this is about Singapore. So yeah, what is happening in Singapore is that according to the latest mental health studies, 1 in 10 Singaporeans might have mental health issue in their lifetime. So, and then many of them will be likely to face depression. That's the most common mental disorder in Singapore as well as across the world, right? And it's projected to affect 170,000 adults, with more women affected by men. Yeah, so this is getting serious, and the others may be affected by alcohol abuse or OCD. Yeah. So it strikes young, okay, and the majority of mental illnesses occur by 29 years. Unfortunately, most of them do not seek help. I mean, same as Malaysia, Indonesia, or other parts of Asian countries. Yeah. And fewer than 1 in 3 approach people such as psychiatrists, caregivers, you know, or the spiritual healer. And like what some of my friends said, most of them will believe that they are being possessed by evil spirit, or they'll seek help from the bomo or the medium rather than seeking help from the professional in Singapore. This is really sad and disturbing. Yeah. And those who seek help will take a long time to do so, and the average time will be around 4 years for people with depression and 13 years for those with alcohol abuse. I mix up the word abuse. Okay, so this is an article done by one of our researchers in Singapore, Prof. Chong Sao An, and he realized that Singaporeans fear mental patients. And people are afraid that they might be dangerous after reading all the negative reports on the behavior of people with mental health issues. So this is about advocacy. Again, I can repeat the word advocacy, advocacy, advocacy. Okay, over here. So this the definition is an important means of raising awareness of mental health issues and ensuring that mental health is on the national agenda of the government. And advocacy can lead to improvement in policy, legislation, and service development. And what is it about stigma? Stigma is something that a person, that causes him or her to have, compromised social standing, a mark of shame, discredit. Many people with serious mental disorder appear to be different because of the symptoms and side effects of the medication. And other people may notice the differences and fail to understand them or feel uncomfortable with them. So they react in negative ways towards them. So these are some of the common misconceptions about people with mental disorder. They are perceived as lazy, unintelligent, unreliable. These are the whole list, and I really see the need to clear the myth in Singapore or maybe other parts of the Asians as well. Okay, what are the effects? That is like unwillingness of people with mental health issues to seek help, or isolation, making it difficult for them to have friends, or damage to self-esteem or self-confidence, denial of adequate housing, loans, health insurance, and family members are more socially isolated and have increased level of stress. And we have come together and worked really hard to decide on what are the actions to take to fight stigma and encourage early treatment in Singapore. And first of all, we need to raise a lot of awareness. And the second thing will be about education, to educate the community on the signs and symptoms of mental disorder, the importance of mental health, and a list of resources in Singapore. And to provide training to all the stakeholders in the community, and also to provide counseling. I'm going to elaborate further. So what is Silver Ribbon about? It was started by this nice lady named Jean in the United States in 1993. She has a son with schizophrenia, and she decided to start Silver Ribbon. And Silver Ribbon symbol generalized support and funding for research and support for mental health. And you can find Silver Ribbon in Japan, Mexico, UK, and India. So I'm the one leading Silver Ribbon Singapore, and you see a beautiful picture. What's so special about this is that previously I was working in one and only mental health institution in Singapore, that's Institute of Mental Health. And over there, I observed that many people had a lot of concern coming forward to seek for help. And I was telling my professor, no point having the best facility in Singapore, but nobody is coming forward. They have a lot of concern. We need to do something. So I wrote to Jean in US asking for her permission to start Silver Ribbon Singapore, to introduce the symbol in Singapore. And then I invited somebody really important. I was telling my board, at that time I was the only one full-time staff. I was the only staff there in Silver Ribbon Singapore. And I have a board governing me, board members. And I was telling my board members, we need to launch Silver Ribbon Singapore. And they were asking, who do you have in mind? I said, President of Singapore. And they were saying, are you crazy to get the president to launch? We are the only staff. It's such a small organization. But I was telling them, mental health issue is a very important issue. We need to get somebody really equally important to launch this initiative. And we managed to invite our president of Singapore, that is S.R. Nathan. So it's very encouraging. It's almost impossible, but it did happen, and it was launched in a very, very busy area in Singapore. And we have a crowd of 3,000 people during our launch. And right now we are commemorating 10th anniversary. We are launched in 2016, and we are commemorating. Yeah, so the thing is, we have 500 over volunteers, and of different background. They could be psychiatrists, nurses, teachers, students of different background, coming together to volunteer at our events. And we reach out to the grassroots organizations, because the grassroots leaders are the ones that come in contact with the residents and the community. So we work closely with all the grassroots leaders. And we work closely with the policy makers. So over here, right in the center, we have Prof. Fatima Latif. She's the member of parliament. And she's like always wanting to support mental health initiative. And when she came to me, I suggested to set up a mental wellness task force at her constituency, so that you will see all these faces. They are the representative of different mental health organizations coming forward together to assist the residents at her constituency. So we call it a task force. And her constituency name is Geylang Serai. Yeah, this is what we are doing. Reaching out to the school institution. What are we doing? So we work closely with the school institution to brainstorm and develop some of the training program, psychology program at the Polytechnic. We work with James Cook University to have Stand Up Stigma Mental Health Carnival at Orchard Road, the most busy area in Singapore. And we commemorate World Mental Health Day with some of the school institutions. And we work together with students to produce video production on psychosis to raise awareness. We have songwriting competition to engage the youth to raise awareness. And we have a play with National University of Singapore to raise awareness. It's never easy. Not many people willing to talk about mental health. We need to make mental health sound sexy, that everybody wanting to talk to you and working with you. Okay? Yeah. So we reach out to the students as well at the different school institutions to raise awareness. And we join forces with some of the government agency to develop this youth mental health program. It's addressed as Youth Support Youth. Not many people like to be seen knocking on the door of their school counselors. It's a stigma to get help from a school counselor. What do? We provide this support program that is we train youngsters, students, to recognize the early signs and symptoms and provide peer support to their classmates. So now this is the 3-day training program for the youngsters. We provide internship program up to 4 months for students of different school institutions to offer a platform for them to understand what is actually happening in Singapore, to expose them to the real world so that they understand the needs better. We will with Cambridge to develop this mental health portal for the students in case they are in need of some emotional support. See some of them smiling. Okay. So we are working closely with the media on some of the programs on the TV, work closely with the producer to make sure they adopt the appropriate terms to use when it comes to mental health. We have been organizing talks and free talks at the libraries to reach out to the readers of the library. We have a lot of branches of libraries in Singapore, and it's free of charge. And then we jointly developed this play, and we have a post-event talk for those who attend this play or center tak otak or something like that, otak tak center, something like that in Malaysia, right? So we had art market to exhibit and showcase the talent of people with mental health issue, rather than always assuming them as a sick role. We showcase the artwork. So we have Darren, we are able to show his face. He has appeared on TV many times. We'll talk about his condition. He's suffering from bipolar disorder. Look at his beautiful artwork. It's really beautiful. Then we have a lot of art exhibition, okay, all around Singapore. And on top of that, what's next? That is like to provide a platform for people to enter into your center to seek for free counseling. We do not have to pay a single cent. We will really assessing why are Singaporeans delaying their treatment. It could be their worries over the treatment cost. They are worried, and they are worried about entering the mental health institution to post their inquiries. So we collaborated with 4 policy makers to operate a center at each constituency to provide free counseling, where people will feel comfortable to come forward to inquire on mental health issues. So over here we provide a platform for our team to clear the myths and to update the residents staying at those areas on the mental health services available and link them up with the mental health agency. This is what we have been doing. So we have 4 of them. And we have a very sexy name. We don't call it mental health center. Rather than the first one is called a wellness studio, right? And second one, the linkage, link the all ages. And the warm corner, that's Woodlands Advocacy for Resilient Minds. The warm corner. Then we have Raintree Century, something that make people feel comfortable to come forward to seek help. Yeah, and we have a very informative website where people can visit. And we have a Facebook page, where people feel free to talk about mental health. Feel free to join Silver Ribbon Singapore website, Facebook. And we update them on a whole list of mental health events by Silver Ribbon, as well as other mental health organizations in Singapore. So we have published a number of booklets to raise awareness. And the first one, let me see. Yeah, the first one is a handbook for the library staff. And during the past, the library staff were sharing that wherever somebody has a bit very strange behavior at the library, they will call for the police to arrest them. Wherever they relapse at the library, they will call for the police to arrest them. This is really bad. And when I was speaking to the National Library Board CEO, I was saying that, can I have a chance to speak to all your library staff? What are their concerns? And after collating their concerns, I worked with them to develop a handbook so that they are able to recognize the early signs and symptoms and know how to engage them, rather than always calling for the police. The second one would be a handbook for employers and employees, because most of the time, employment is always an issue when it comes to mental health. And it's really hard for people with mental health issues to secure a job. And why? We need to understand. And when I spoke to some of the employees, I realized that they have a lot of concern. So with this booklet, they have no excuse saying that I do not know how to handle anyone with mental health issues. So we are circulating this free of charge as well. It's supported by the speakers of the parliament. Yeah. So we have launched this last October, handbooks for grassroots leaders. And over here, and I was approached by one of the People's Association, and they funded us to distribute this book to the community, to the population, totally free of charge. And I have to come up with a very special title, Mind Your Business. Embrace mental health. I have few copies with me if you're interested. So pick up. Yeah, so we do conduct mental health first aid as well. It's a 2 full-day course to train staff of NGOs or organizations on how to recognize early signs, symptoms, and handle mental health crisis. So we reach out to the voluntary welfare organization, that's what you call NGOs over here. We set up communities of practice for mental health. So we gather all the social workers in Singapore who are handling clients with mental health issues and providing a platform for them to share their concern and hoping to retain them in this sector without resigning. Yeah. So we launched this mental health resource kit for caseworkers in Singapore, hoping that they'll stay longer in NGOs without much fear, yeah, of handling people with mental health issues. Yeah. So other collaboration, of course, like we start reaching out to the migrant workers. They could be experiencing high level of stress in Singapore and may end their life due to high stress level. So we start having cures for the migrants worker in Singapore. And we reach out to the churches as well, the religious group, the church, and we train out some of the church members to be the community mental wellness ambassador. And this is a Chinese character. This is a newspaper cutting to show our collaboration working with the Chinese physicians. So in Singapore, we have high population of Chinese staying in Singapore. And they are very concerned about seeking for help. They worry about the side effects of the medication. So most of them prefer to turn to the traditional Chinese medication. Yeah. So on top of that, we make sure we commemorate World Mental Health Day. We have been commemorating World Mental Health Day since 2006. And these are some of our initiatives to commemorate World Mental Health Day. 2011, we climbed the wall, the Biafra Tower wall to raise awareness. So it's a hot challenge. You can look at that, the hot challenge. Hang on there for people with mental health issues. It's at Orchard Central. So we did that to raise awareness. And this is me. Okay? And the owner of this shopping mall was telling me, Posh, I dare you, if you dare to complete that 3-story height of wall, we will donate 10,000 to Silver Ribbon Singapore. And I did that. I did that. It's very scary, okay? I have phobia of height. Yeah. And 2011, we had 1,200 people forming human chain formation of Silver Ribbon to raise awareness. And all these 1,200 people are of different backgrounds. It was led by Prof. Fatima Latif to commemorate Women Health Day. 2012, we have a celebration at one of the regional libraries in Singapore. We have art exhibition, we have talks, a whole list of exciting events happening at the library. Look at this beautiful picture. That's a collaborative effort. We have the Minister of the State, Grace Fu, and the Chief of the Library. We have psychiatrists, consumers, caregivers, library staff, involving lecturers and students volunteering at the event. This is what we emphasize on, collaborative effort to fight stigma. Yeah. And this is another event, Community Wellness Carnival that we did. Okay. And 2013 again, okay, we have our community wellness carnival. So we have been working really hard to reach out to the people through innovative means. Look at this. This is a very daring project in 2014. We commemorate World Mental Health Day on the same day, same time, at 4 constituencies, supported by 4 members of parliament. All happening on the same day and same time, and our theme was, it's time to care, celebrate, advocate, reflect, and educate people on mental health issues. And it was very successful, really successful. I was really glad. So we have event highlights such as mental wellness talk, booth exhibition, performance at those 4 constituencies. And 2015, we organized a regional congress of World Federation for Mental Health. And again, it was very well received. And this year we are having another conference this October, and getting everybody together to raise awareness and educate the community, involving 20 over organizations in Singapore. This is what we talk about, collaborative effort to raise awareness. So what do? We involve all stakeholders, including consumers and caregivers, and they have this tagline, do not do anything for us without us. Okay? Instead of assuming their needs, we should understand the actual needs and address it. And in order to reach out to the community, we have to be very innovative. So you look at that, what's the title? I have mental illness, so what? Okay? Or instead of having mental health talk on psychosis, Friday the 13th, psychosis versus possession. So if we invited a psychiatrist to debate against a paranormal investigator, and for Chinese, secret, for the name. Yeah. So we reach out to everyone of all backgrounds, of all age groups, cultures, and races. This is very important. And we engage the policymaker. So we have involved almost every policymaker in Singapore. And after involving in our mental health events, they become more vocal at the parliament meeting. And as a result, they are pumping in more money to make a change. So of course, like many of the speakers today talk so much about the research and figures, there's still no scientific evidence that advocacy can improve the level of people's mental health. Okay? But the thing is, we are able, by doing all this, raising awareness, we can place mental health on the government agenda, and you see that most of the policymakers are very vocal, and they're speaking and sharing, and there's improvement in the policies and the practice of the government. And we see that everybody are talking about, collaborative effort to promote mental health and fight stigma, and indirectly, we are improving the interests of people with mental health issues and their caregivers. And we improve the mental health services and treatment and care. So this is what I want to share. Thank you so much.
Thank you very much, Portia.
Yeah.
I think it's a very interesting complement to the other 2 talks that we've had. Not merely in the sense of advocacy as opposed to research, but it raises the issue that, in a sense, anything that you do in this context is actually going to involve cultural change as to what is mental illness. Do you have that category to begin with? Or we can have a discussion of kind of to what extent this is a good thing and what have you. What questions do we have?
I have a question since the beginning, which
Yes.
goes a little bit in the line of what you just said. I was particularly impressed by your presentation because I deal with Indonesia, and but the same can be said for I know presentation. It seems the medical definition of mental illness is given for granted, and it's never, except in Portia's last bit, which was very interesting. But of course, Singapore, you can't even get crazy in Singapore without being involved immediately. But it's as if when the question is raised, but what do you define as a mental illness? Why should people consult? How is it going to change for them if they enter that kind of categorization? I'm not talking of the urgent need to let people free from being chained or shut up or locked in, but something more critical about the definition of mental illness and this ideal cure, which we don't really know. I deal with drug addicts in Indonesia, and everybody is calling for rehab programs and all, but if you get deeper into what is worldwide stated about people who have a dependence on crystal meth, for instance, nobody knows what to do with them. So it's very difficult for me to see how a good program can be implemented without a good critics on that plan. It seems to me it was like a 100% medical, psychiatric understanding of mental illness, like following the DM4 or 5, depending on inklings. So I would like to know if you have, either of you has a little bit more idea concerning this level.
Even if we follow the DSMs, either 4 or 5, there's always a part of the clinical diagnosis which requires whatever disturbance the person is experiencing to significantly disturb their daily activities of living. So we might have people with signs of schizophrenia, for example, delusions and hallucinations, but not be affected by it at all. And I would say that these people may not need mental health care as urgently as people who find it very disturbing, of course. So of course that's where the clinical interviewing comes in.
Einol, did you want to come back?
Well, for me, I'm focusing more on policy, the implementation. And I'm not planning to quantify anything. So it's a more sort of based on the experience and observations of the stakeholders. So although yes, I do admit, the study site that I'm focused upon is the Hospital of Kuala Lumpur, which I did not actually share before. But they themselves have a community mental health care. So they go to houses and therefore they do focus a lot more on the psychosocial aspect of it. So it from where I'm looking at, my study that is I'm not really limiting it to just medical, but it's just that, whoever that is within the mental health system, whoever have probably access or experience or even observe, can be included in the study. Of course, for as long as they fit into my 5 stakeholder groups. I don't think from where I'm coming from, or at least for my study, it's a medically inclined sort of study. I'm a lot more inclusive in art when it comes to this. Yeah.
Other questions?
My question is, I guess, kind of specific to Posh, because I was just wondering what is, whether you have worked with MOE, and secondly, whether the Ministry of Education is actually doing anything in that sense about mental health, I guess.
For Ministry of Education, they are planting one school counselor in each school to attend to students with emotional issue. And on top of that, they are working closely with Institute of Mental Health, running a team called the REACH team, REACH, where they will provide free treatment to kids or youngsters with mental health issues.
As in, I asked that more in line of because for me, I'm going to be teaching in Singapore, and likewise, I've also every summer, every time I go back, I try as much as possible to go to a classroom to try to still keep in touch what Singapore school kids are like, having lived in the UK the past 4 years. And what I realized is not just my peers in the UK, but also my peers back home in Singapore, and also the kids that I see in the classroom. A lot of them seem to have increasing. I'm not very sure if this is a mental health issue, because I'm not trained in that sense also. Is that there's an increasing problem with things like Instagram and their perception of body dysmorphia and things like that, which for me, I was just wondering whether any of you have anything to comment about what as educators we can do when it comes to dealing with kids who are not necessarily, I'm not sure if they are considered mentally ill, but at the same time are showing early signs of these kind of likely problems also, I guess.
It's good for the teachers to be trained to recognize the early sign symptoms. At least they are able to detect all the warning signs and able to refer the student to the school counselor for help.
Yes, please.
My question is related to the Singaporean experience. What kind of language do you use when you try to advocate your project with the politicians? In a sense that when you mention that you cannot use advocacy because it's somehow referred to disruption of order, I'm just wondering what kind of
The appropriate terms.
terms that you use to appeal them to tackle problem of mental illness.
I would like
because
to
it's so
share.
disordered.
I would like to share with you, I did raise awareness that we have 4 branches at the different constituency. It's never easy to encourage the policy maker to collaborate with us because they have a lot of concern by allowing us to operate a mental health facility at their constituency. They might lose some votes. They are afraid it might affect the values of the living, the unit that they're staying. So they are always very concerned. But the thing is, like, we have to weigh, because we kept reminding the policymaker that they have a responsibility. We have to work closely together. If not, residents start exhibiting very strange behavior. What would they do? They start disturbing their neighbors. As a result, the neighbors will start writing to the paper and make a complaint saying the government is not doing anything. So as a result, policymakers are more willing to work with us to recognize and acknowledge that there's a need to collaborate with NGOs in order to address the needs of the residents. And they see the effectiveness. Yeah. Okay.
The fact that you have a number of different audiences that you're speaking to, and of course some of it's in English and some of it's in Chinese and other languages, it occurs to me that the first question that was asked, which was directed mostly at Sabrina, I know, actually might be addressed to you as well. I mean, to what extent do you see yourself as raising awareness of mental illness? And to what extent are you actually an agent of cultural change who is constructing a category or a set of classifications of what counts as mental illness in Singapore or Javanese? I mean, we found working in Javanese and Sundanese and Minangkabau, you could ask questions in Bahasa and get very clear answers. When you shifted to the local language, you got 2 paragraphs. And it usually meant the opposite of what the one-line answer in Bahasa was. And I'm sure this would be true on mental illness issues. I mean, it had to do with aging. Are you basically an agent of cultural change? Is that what you do?
Try really hard to adjust their mindset. I mean, the perception towards mental health issue is never easy. Like what I have said, most of the people assume that they are being possessed by evil spirit. We have to. That's why I
So
see
you
the need.
don't want them to think that anymore.
No.
So
We
you
do
want to
respect
change.
all
You want to change what they think and how they explain
Yes.
whatever it is which they see as spirit possession and we see as mental illness.
Yes, yes.
Okay.
And we need to emphasize during the first few sessions that we do respect all religious group. We do, no. But if the symptoms or the behavior perceived for a prolonged period and start affecting the daily routine, then there's a need to seek for appropriate help. So they are open to that. They're open to that. Yeah.
I think,
Yeah.
I think what we all kind of are advocating, I mean, especially because this is a Southeast Asian context, is that we're not discrediting the cultural beliefs, but then it's just, trying to educate as to when do you seek for, where, to what extent is this a mental illness, and to what extent is this really, a sort of a spiritual matter, because I am a Muslim myself, and to some extent I do admit there are some spiritual, it can be true,
Yeah.
but it's just educating people, okay, after a certain threshold, this no longer can be deemed as a cultural or a spiritual matter, no longer in that sense.
Or could it be both?
That is something
the kinds
that,
of issues that
yeah,
we're dealing with
yeah.
cut across a vast
Yeah.
range of issues. I mean, the malaria research that we're doing, in a sense, it's quite clear that
Yeah.
everybody knows that there's the mosquitoes and you go and get your chloroquine or whatever it is. Why did you get malaria? Well, because you stole a papaya from your neighbour's garden and he, put a curse on it. And that's really why you get malaria.
Yeah.
We all know that.
Yeah.
These coexist. But there is an interesting question whether, in a sense, both from a science and advocacy point of view,
Yeah.
what you are trying to do is actually change the relationship between
Yeah.
these different cultural understandings.
Yeah.
Somebody else come in, because
I think that, sorry, I don't want to monopolize, but I think that you touched upon an important word. There's the border between a moral definition and a spiritual one and a medical one is
Yes.
blurred.
Yes.
But it goes the same for the handling of a difficult situation. If you try to, in a certain way, if you try to keep the blur where it is, then it will work on all the levels. It's interesting also, in my experience, which with possessions and similar stuff was quite extended, people would acknowledge that there was something, sometimes people were gila, but at the same time, a person who was handled by an appropriate medium could in fact solve an everyday life problem, and at the same time be morally satisfied. Whereas in acknowledging mental illness, morality is just kept at bay, and it can. I don't think. In my experience, it can hinder cure or help.
I completely agree to that, because from that's what with my study I am not actually defining what is mental health, mental illness itself. That's why I gave the definition of mental health to the Malaysian context, and therefore I am trying to sort of explore myself to what extent the spiritual assistance or the more traditional assistance can be useful, and therefore come up with a plan, moving forward with an improved policy that can perhaps collaborate this. Because from what I'm seeing from my data right now, yes, there's already people saying, yep, it's helping. There's you can't discredit that. So I do agree with you on that.
So with regards to that, in Indonesia, in the 1970s, there are lots of research done on mental illness and dukun, traditional healers. And it was found that dukun may not adequately resolve the disturbances that person with early psychosis may be experiencing, but they feel better after seeing a dukun. And it is only when the symptoms don't go away, although they feel better, that they seek medical attention. And unfortunately in Indonesia, based on my observation, mainly in Java, mental illness, when it's medicalized, is less stigmatized compared to when it's considered demon possession or being sinful or being
Interesting.
cursed.
That's really interesting because in Malaysia it's the other way.
Yeah, I know.
Yeah.
But also, well, I don't know, it's a complicated matter.
Yeah,
but
it is.
New categories which include
Yes.
both like trauma.
Yeah.
It's being started in nutshell, not
Yes.
of course because of many traumas, but people have elaborated a category of trauma which is, sorry, which includes both the medical and the spiritual and the social too. So that's
Yes.
but trauma means I also am entitled to money for it.
Yes.
So,
Yeah.
it's very interesting.
This has been, I think, a very good discussion, and I think it's got to the heart of the issues which are really kind of
That's
raised,
interesting.
which we can't solve here. If anybody has a question to earnestly want to ask, please do so. Otherwise, I shall shut the whole thing down. All right? Well, thanks once again to our three speakers, who were very articulate and clear and very interesting.
Yeah.